Welcome, YouTube. It's the finale time. We did it. We did it. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel the Riley. Welcome, YouTube. All right. We pick up in the last chapter. Page 505. In the middle. This is episode 82. Wow. It's amazing. It really is. All right. Lung contusion. Although lung contusion is not clearly defined, it generally refers to the phenomenon of interstitial pulmonary bleeding following chest trauma. Lung contusion rarely produces symptomatology in the first few hours following trauma, but may result in significant hypoxemia and decreased compliance in the first several days following chest trauma. Severe lung contusion presents on chest x-ray as a totally white lung and has been referred to as the white lung syndrome. When lung contusion is unilateral, it seldom causes life-threatening cardiopulmonary embarrassment, since the hypoxemia is reasonably supported by appropriate oxygen therapy. When lung contusion is bilateral or unilateral in conjunction with a flailed chest, it is often life-threatening and requires airway pressure support. The major requirement for airway pressure support appears to be the poor lung compliance. Thank you so much for being here in this peaceful part of YouTube. We read books and learn from masters, and this is the finale of Clinical Application of Respiratory Care. We're in the 34th chapter, page 505, down in the middle. All right. The combination of lung contusion and flailed chest has probably led to overtreatment with volume ventilation and fluids, resulting in worsening of the contusion. In addition, the fluids resulting in a need the ventilator for his flailed chest when the contusion clears. Sound clinical judgment and serial cardiopulmonary evaluation will provide the proper approach for each patient. Do not overtreat unilateral lung contusion or minimal flail chest. Pulmonary embolism. The true incidence of the pulmonary embolic phenomenon is not clear. The general belief that the phenomenon is very common stems from post-mortem examinations, which suggest an incidence as high as 60%. These figures may be clinically applicable to elderly, chronically ill, malnourished, and post-surgical patients, but certainly not to the population as a whole. The diagnosis of pulmonary embolus is uncertain and difficult, and is missed as often as it is misdiagnosed. The problem of diagnosis is compounded in patients manifesting acute respiratory failure. To the respiratory care practitioner, pulmonary embolus remains an enigma and an elusive entity. The basic principles of respiratory care must be applied, and the diagnosis of pulmonary embolus never taken as a certainty unless documented by pulmonary and angiography. Status asthmaticus. Rarely, an adult asthmatic undergoes an acute exacerbation that is unresponsive to aggressive medical therapy. In such a circumstance, the thick mucus secretions have become the major hindrance to maintaining adequate external respiration. The hallmark of status asthmaticus to the respiratory care practitioner is carbon dioxide retention. Suggested therapy is as follows. I want to take notes on this, all those, and for the replays, and we'll put in the description the vocabulary. So thank you so much for being here. Thank you for the likes and subs and being in this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Neville Riley. So thank you so much for being here. All right, page 506 in the middle. 1. 48 to 72 hours of controlled positive pressure ventilation. Very heavy sedation with morphine sulfate is advised to assure unconsciousness and eventual reversibility. Pharmacologic paralyzation is advised to assure optimal chest wall compliance and tolerance of bronchial hygiene therapy. All right. 2. Tapering and discontinuance of bronchodilating drugs during this period with maintenance of steroid, antibiotic, and fluid therapy. 3. Placement of a large, stable endotracheal tube so that the thick, tenacious secretions can be mobilized without obstructing the airway. 4. Frequent aerosol and chest physical therapy, CPT. Within 24 hours, the mobilization of secretions should become copious. 5. Following 2 to 3 days of sleep, bronchial hygiene, and minimal bronchodilating drugs, the patient should be awakened, reverse morphine and relaxant, and extubated immediately. The disease is usually pharmacologically controllable after these steps. However, occasionally the process must be repeated 3 to 7 days. Adult cystic fibrosis. Oh, ooh. The disease entity cystic fibrosis is worthy of special note because it is the major chronic lung disease of childhood and young adults. The chronicity involves the need for continuous respiratory care. Cystic fibrosis, or mucoviscidosis, is a triad of 1. Chronic pulmonary disease, 2. Pancreatic deficiency, and 3. High chloride content in sweat. It may be thought of as a disease of exocrine glands, which includes the mucus and serous glands of the pulmonary mucosa. The pathology is essentially bronchial obstruction with infection. Primary involvement of the lung parenchyma is minimal. Autopsy findings typically are bronchiolitis, bronchitis, plugs of tenacious yellow-green mucus clinging to bronchi, bronchiectasis, patchy atelectasis, extensive pneumonitis, and numerous small pulmonary abscesses. The clinical course shows repeated pulmonary infections, hypoxemia, and difficulty maintaining bronchial hygiene. This eventually leads to pulmonary hypertension, cor pulmonale, and death. Carbon dioxide retention occurs late in the disease and is commensurate with the onset of heart failure. In our experience, most patients die within 1 year of the onset of significant CO2 retention. Wow. Sheesh. Oh, look at that. Peace. Awesome. Thank you so much. All the book lovers and book lovers community. Highest heart love. Thank you so much for being here, reading in this finale with us. This is a beautiful thing. All right. So that's a big one right there. Within 1 year of onset of significant CO2 retention. Okay. That's with the retention. That's why the exhale breath, the release breath, the out breath is so important. So we're not retaining the CO2. Have to put a pin there. Make sure that we're releasing our breath. That's the lesson of the lungs in the meridians. Okay. So here we go. Respiratory care involves judicious and appropriate use of antibiotic and oxygen therapy. Bronchial hygiene is essential and must involve aggressive chest physical therapy, CPT techniques, in a continuous home program. Ultrasonic aerosol proves beneficial to bronchial hygiene in the vast majority of patients. More controversial is the use of IPPB, mucolytics, and decongestants. Our experience has shown that continuous home therapy is best composed of ultrasonic aerosol and CPT. Acute infections with impending decompensation must be treated in the hospital with oxygen and antibiotics. During these episodes, we believe the cough is best augmented by IPPB. The addition of mucolytics to the aerosol may be beneficial. Pediatric respiratory care. The medical specialty of pediatrics evolved because the small child, and especially the infant, cannot be treated as little adults. Separation of pediatric patients into age groups is arbitrary. We shall use the following guidelines. 1. The newborn is from birth to 48 hours. 2. The premature is a newborn under and 5.5 pounds. 3. The neonate is from 2 days to 2 weeks of age. And 4, the infant is from 2 weeks to 2 years of age. 5, the preschooler is from 2 years to 5 years. And 6, the child is from 5 years to puberty. Table 34.2 shows the normal ranges of vital signs for these age groups. All right, here we go. This is table 34.2. Normal ranges of vital signs in pediatrics. Peace. You too. Welcome. All right. So it says for newborn age, first 48 hours and weight 6 to 9 pounds. RR 40, pulse 120 over to 140, and the BP systolic is 50 to 90. The neonate is 2 days to 2 weeks. Weight is 6 to 10 pounds. RR is 40, and pulse is 120. BP systolic is 75 to 85. Infant is 2 weeks to 2 years, and the weight is 8 to 25 pounds, and the RR is 25 to 30. The pulse is 120, and the BP systolic is 80 to 90. Preschool is 2 years to 5 years. Weight is 25 to 45 pounds. RR is 20. Pulse is 100 to 110. And the BP systolic is 80 to 100. And child is 5 years to puberty. And weight is 45 to 80 pounds. RR is 16 to 20. Pulse is 85 to 100. And BP systolic is 120. All right, so this is table 34 2. Thank you so much. Down at the bottom right here. Thank you so much for reading with us. Hi, it's Heart Love. Yes, we are in the final chapter and final reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So there you go. All right. Page 508 at the top. Although there are differences in respiratory care requirements between the child and the adult, these differences are primarily of technique and behavior rather than physiology. We shall limit our discussion of pediatric respiratory care to the age group under 2 years and compare the significant anatomic, physiologic, and pharmacologic differences with those of the adult. The role of oxygen therapy and bronchial hygiene techniques and the disease entities peculiar to the newborn and the infant will be discussed. The principles of pediatric respiratory intensive care are beyond the scope of and intent of this text. Pulmonary anatomy. The infant tongue is larger in proportion to the body size than in the adult. Therefore, extending the neck and moving the jaw forward may not relieve soft tissue airway obstruction. An oral airway is often necessary. In comparison to the adult, there is a tremendous amount of lymphoid tissue in the pharynx. This, together with a large tongue, makes lymphoid hyperplasia extremely threatening to upper airway patency. The infant epiglottis is extremely large, U-shaped rather than V-shaped, and very susceptible to trauma. The infant larynx lies higher in the neck than in the adult. The narrowest portion of the larynx and trachea is found at the level of the cricoid ring in the infant as opposed to the glottis in the adult. Thank you so much. Woo! Super high level books. We're about to complete another one here, live from the light here in LA. Thank you so much for being here. All of these factors make the presence of edema or infection serious threats to upper airway patency. The respiratory care practitioner must be aware of the great increase in airway resistance and the increased likelihood of obstruction in the infant. At birth, the bifurcation of the trachea is at the level of the third thoracic vertebrae, and by 12 years is at the level of the sixth thoracic vertebra. Wow. Wow. Woo! I love anatomy. Don't you love it? Oh, I love anatomy. That's deep. Wow. It moves from the level of the third thoracic vertebrae all the way to the sixth thoracic vertebrae. Wow. The tracheal diameter increases about threefold from birth to maturity, being approximately 6 millimeters in diameter at birth to 12 millimeters at age 6 and 18 millimeters at adult. Airway infection or inflammation will be a greater significance in the infant than the adult. The neonate's ribs are more horizontal than the adults and therefore provide little leverage to increase AP diameter. Ventilation is much more dependent upon diaphragmatic breathing in the early years of life than in the adult. Ding! So key to be able to recognize in the adult, it's not as necessary to always diaphragmatically breathe. And this is what happens with us. We start to get comfortable, right? Not breathing correctly. So, this is why we're reading this book to reinforce the care and love and that diaphragmatic breath. Thank you so much. Oh my goodness. We had to put a pin right there. Definitely, and taking notes. That's one key, right? All right. The neonate's ribs are more horizontal than the adult and therefore provide little leverage to increase AP diameter. Ventilation is much more dependent upon diaphragmatic breathing in the early years of life than in the adult. In the newborn, the sternum is extremely soft and offers little stability to the chest wall. Pulmonary physiology. The neonate is instinctively a nose breather, breathing through the mouth only when crying. Wow. Anatomic dead space increases steadily as size increases. The rule of 1 milliliter per pound of body weight holds throughout life. Obviously, absolute increases in dead space are of greater disadvantage to the smaller patient than the adult. Cardiopulmonary reserve. Page 509. An infant has a greater cardiovascular reserve than an adult. The non diseased infant has a resilient cardiovascular system capable of meeting significant degrees of stress. The pulmonary system has little reserve in the normal infant because of 1. Poor stability of the chest wall, 2. A large heart, and 3. A large abdomen pushing up the diaphragm. Mm, mm, mm. Infants have little ability to increase tidal volumes in relation to adults. Therefore, infants prefer to increase ventilatory rate rather than depth of ventilation. Healthy newborns can double their ventilatory rate from 30 to 60 per minute without any appreciable difference in the work of breathing. Surface areas. Bottom of page 509. Surface areas. The smaller the patient, the greater the relative surface area. A newborn has 9 times greater surface area per unit body weight than the adult. By 6 years of age, the difference is only twofold. Skin plays an important role in heat regulation and fluid balance. The infant has much more rapid fluid utilization than the adult. Approximately 80% of the newborn's total body weight is water, compared with 55 to 60% in adults. And we already know this, right? But again, we're reinforcing information. All those aspiring nurses and doctors and MTechs, we thank you so much. Like my final reading, I'm getting phone calls. It's hard enough. All right. So, in the infants, extracellular fluid is the greater part of the total body water. Intracellular fluid is the greater part of total body water in the adult. Since it is the extracellular fluid that is rapidly utilized for metabolic function, the infant has a rapid turnover of this fluid, making dehydration and fluid overloading a significant problem. In addition, decreased bicarbonate and buffer activity makes acid base balance easier to upset. Pharmacology, page 510. Wow. Infants and children do not react to drugs in proportion to age, weight, or any other known relationship. The response to any medication may be different in intensity, action, side effects, or toxicity. Altered response may be due to the type of medication, the maturity of the central nervous system, the metabolic activity of the child, or enzymatic and endocrine activity. In addition, the effects of many medications vary with the emotional state of the child. It must never be assumed that infants should take simply smaller doses of the same medications. Mhm. Very key. Our guidelines for aerosol bronchodilators are as follows: isoproterenol or isoprel, maximum infant dose 0.65 milligrams per treatment, or 1/8 milliliter of 1 to ratio 1 to 200 ratio isoproterenol diluted in 2.5 milliliters of normal saline. These dosages are doubled for the older child. For decongestion, we recommend racemic epinephrine, a maximum of 1/4 milliliters in 2.5 milliliters of normal saline per treatment. The effectiveness of mucolytics in infants is unknown. With the exception of cystic fibrosis or lung abscess, there appears to be little rationale for the use of proteolytics or mucolytics. It has been our experience that, with the exception of the cystic fibrotic patient, good hydration and aerosol therapy are far superior to the administration of mucolytic agents. Delivery or respiratory therapy. Delivery of respiratory therapy. Technical differences in the application of respiratory care exist between the infant and the adult. The sick neonate, premature infant, or small infant requires a temperature regulated, oxygen controlled environment. An infant with a respiratory problem needs isolation, warmth, and humidity. It was established many years ago that the lowest mortality in infants is found when they are placed in a neutral thermal environment. An infant's body metabolism is lowest when the infant's skin temperature is maintained between 36 Celsius and 37 Celsius degrees Celsius. At this temperature, the infant has the lowest oxygen consumption. Cooling or overheating will increase body oxygen consumption. Yeah. Because the infant must be accessible for routine nursing care and monitoring, it is difficult to control the temperature, oxygen atmosphere, and humidity. Although many pieces of equipment have been introduced, the incubator has proved itself the most dependable. Numerous new techniques, such as heat shields and heat hoods, are being tried and may well prove to be excellent environmental control devices. However, at present, the incubator is still the standard device for infant care. Page 511 at the top. Oxygen therapy. We are in the 34th chapter, the last chapter. Thank you so much. We're doing it. Amazing. Amazing. We are the champions of reading on YouTube. That's for real. Definitely. Oxygen therapy. Of prime concern to the respiratory care practitioner is maintaining appropriate oxygen therapy for the infant and neonate. There is nothing that can assure consistency except the monitoring of arterial blood gases in coordination with clinical assessment. Most blood gas samples are obtained by capillary stick in the infant. Masks are poorly tolerated by infants, and temperature and humidity obviously cannot be controlled by masks. Thus, incubators or oxygen tents are still the means of choice for infant oxygen therapy. The premature, newborn, and neonate may require incubator care with supplemental use of oxygen hoods for specifically controlled inspired oxygen concentrations. Aerosol therapy. There is more need for therapy techniques that reduce airway hyperemia and edema in the infant than in the adult because airway edema is a greater potential insult in the infant. Decongestants are more frequently used. Mist tent therapy is more effective for infants and small children than is mask therapy. Studies on particle deposition in the lower respiratory tract in tent therapy have shown that as little as 5% of the nebulized fluid entering the tent was retained by the subject in the lower respiratory tract. Most was deposited in the upper airway and swallowed. It has been suggested that the value of mist tent therapy in infants is not that of particle deposition, but that of guaranteeing a high humidity in inspired air, thus decreasing the evaporative loss via the respiratory tract and decreasing the likelihood of dry retained secretions. Here's a key right here. This is what we use with our love. Here we go. Distilled water is used in tent therapy. Since saltwater solutions are irritating to the eyes and can potentially cause electrolyte imbalance. Perhaps the greatest danger with aerosol therapy is the wetting and initial mobilizing of secretions. Without sufficient attention to helping the infant mobilize the mucus, either by suctioning or stimulating a cough. IPPB therapy. The technical difficulties of applying IPPB therapy in the infant are obvious. However, the main reason for not using IPPB therapy in infants to any extent or to any great extent is actually not the technical difficulty, but the fact that there is little indication for its use. The only advantage of IPP therapy seems to be the effective delivery of topical vasoconstrictor drugs for decongestion. There is good clinical evidence to support the contention that many patients with infectious croup can be appropriately treated without the need for a tracheostomy or endotracheal intubation when racemic epinephrine is properly delivered by IPPB. In the asthmatic or the cystic fibrotic patient, we have no evidence that there is any advantage to the administration of bronchodilators by IPPB. The administration of bronchodilators is as effective by aerosol spray or intravenous administration as by IPPB. In older children, IPPB therapy can play the same role as in adults by increasing the effectiveness of the cough and improving the distribution of ventilation. Above all, the general rule for the effectiveness of respiratory therapy techniques is the same in infants as it is in adults. It is dependent upon the skill with which the therapist accomplish the treatment. Much depends on the cooperation of the patient, and this becomes an art in the infant and small child. For example, an infant must be cuddled to become familiar with the therapist before a treatment begins. Therapists must play with the older children and attempt to make the treatment a game. Above all, they must gain the confidence of the child. It's very key. That's very key. Whenever we're dealing with care, it's having the confidence in where we're receiving the care. So we want to make sure we establish that rapport with them. Ask them simple questions about their life that only they could tell you, right? This helps them get comfortable with you. All right. Chest physical therapy. Chest physical therapy is extremely effective in infants and children once the therapist gains the cooperation and confidence of the patient. Because of the infant's size, manipulation into various drainage positions is easy. Pediatric chest physical therapy techniques are discussed in Chapter 12. Pediatric disease entities. The infant pulmonary system is extremely vulnerable to infection. 42%, 42% of all hospital admissions for children under the age of 2 are for respiratory problems. There are several disease entities found in the pediatric age group that demand particular attention and skill from the respiratory care practitioner. Infectious croup. Laryngotracheal bronchitis is termed infectious croup in the infant. It is an acute inflammation of the upper respiratory tract and large airways. The most common pathogen is para, parainfluenza virus. It is commonly seen between the ages of 6 months and 3 years, with the infant often exhibiting signs of laryngeal and sublaryngeal obstruction. See Chapter 17. The inflammatory swelling results in respiratory distress of varying degrees. The infant may exhibit hoarseness, a barking cough, stridor, labored breathing, intercostal, sternal, and substernal retractions. A reasonable differential diagnosis would include dip, diphtheroid, croup, foreign body aspiration, retropharyngeal abscess, upper airway trauma, tumor, and congenital malformations. Aerosol and appropriate oxygen therapy seem to be universally accepted supportive elements in the treatment of croup. Substitution of IV for oral fluids is necessary in the more severe cases. The use of antibiotics, steroids, and decongestants is controversial. All have been used under various circumstances, but their effects on the mortality and morbidity of croup are unclear. Racemic epinephrine or other appropriate decongestants applied topically have been reported to have dramatic effects. When obstructive symptoms are severe, intubation and tracheostomy may be necessary. Acute epiglottis. Thank you so much for the likes and subs. We are pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. So I am so honored and grateful for all of you. Thank you so much. Wow, we're doing it. We did it. Middle of page 513. Acute Epiglottis is usually caused by the organism Haemophilus influenzae and is characterized by an extremely rapid onset of upper airway obstruction. The child is almost always febrile and usually has a low pitched stridor. As the swollen epiglottis pushes up into the hypopharynx, a complete obstruction may occur. Acute epiglottis is mainly distinguished from croup by the fact that it is a supraglottic obstruction rather than a laryngeal or sublaryngeal. Treatment is primarily that of assuring a patent airway. Bronchiolitis. Bronchiolitis is a viral infection that causes swelling of bronchiolar mucosa and production of mucosal exudates, leading to obstruction of the small airways. And it affects mainly the 6 month to 2 year age group. The early symptoms are usually a cold, which may soon be accompanied by a cough, increased restlessness, and a rapid ventilatory rate, which begins to interfere with feedings. Bronchial inflammation is probably no more common in the infant than the adult, but causes far greater symptomatology because small degrees of inflammation result in great increases in airway resistance in infant tracheobronchial trees. Supportive treatment is primarily that of appropriate use of oxygen and aerosol therapy. One must be careful in sedating these children because the restlessness may well be due to severe arterial hypoxemia and tissue hypoxia. In a patient who may be fatigued secondary to increased work of breathing, sedation may result in apnea. Rarely, a patient with bronchiolitis will require intubation and mechanically ventilation while the inflammation subsides. Cystic fibrosis. Cystic fibrosis is a hereditary disease in which there is a dysfunction of all or most of the exocrine glands. Clinically, manifestations of the disease include a chronic pulmonary disease, pancreatic insufficiency, and gastrointestinal symptomology. Interestingly, the electrolytes are elevated in the sweat because of malfunction of these exocrine glands. The pulmonary disease of fibrosis is characterized by clinical infection, resulting in small airway obstruction. Bronchiectasis usually accompanies the bronchiectic component. The frequent infections usually persist, uh, precipitate hospital admissions. Children with cystic fibrosis produce copious amounts of thick and tenacious secretions. The respiratory therapy consists of aerosol and chest physical therapy, which must be carried out in the home as well as the hospital. The benefit of nightly mist tent therapy is widely disputed, but seems to be one of some benefit for the infant. Oxygen therapy should be administered cautiously and judiciously, as in any chronic obstructive pulmonary disease patient. Psychologic support of this chronically diseased child and his or her family is imperative. All attempts should be made to maintain a normal growth process and home environment despite the time consuming respiratory therapy regimens. In the severely symptomatic cystic child, avoiding pulmonary infection, maintaining adequate nutrition, and proper gastrointestinal function are a challenge. The respiratory care practitioner is a vital member of the healthcare team in the treatment of the patient with cystic fibrosis. Bottom of page 514. Respiratory distress of the newborn. Idiopathic RDS, hyaline membrane disease. Acute restrictive disease in a newborn is similar to the adult respiratory distress syndrome. See Chapter 30. It is believed that the lack of surfactant production in infant RDS is due to the immaturity of the alveolar type 2 cell. The infant lungs become progressively stiffer and the functional residual capacity decreases. Lung compliance drops to 20 to 25% of normal. The work of breathing becomes greater along with a profound hypoxemia that is unresponsive to oxygen therapy. Histologic, histologic examinations is similar to that for the adult respiratory distress syndrome. Respiratory distress syndrome occurs in 1% of live births and has incidence of high as 33% in premature births. The cardinal signs are a ventilatory rate above 60, nasal flaring, intercostal and subcostal retractions, and expiratory grunt is common, and peripheral edema with systemic hypotension is found frequently. In the earlier in the early disease state, the arterial PCO2s are below normal with progressive hypoxemia. Carbon dioxide retention is an extremely grave sign and is indicative of a far advanced RDS. If the infant has an increased PCO2, he or she will need ventilator support as well as positive and expiratory pressure. The chest x ray findings are similar to those of the adult, showing a granular honeycomb alveolar pattern with air bronchiograms. The treatment of choice is early intervention with continuous positive airway pressure, or CPAP, right? We know the CPAP. Yes! One of my favorite tools, healing tools, is the CPAP. That's for sure. Put that on, and then we breathe, and I assist them in stretching. And it's just such a powerful healer. And distributor to oxygen throughout the body when you're breathing to the muscles in the stretching position like that. So we use the CPAP with that and to help a lot of people with all types of diseases, including cancers, HIV, and so on and so forth. Ventilator support is avoided if at all possible because of the high mortality of infants on ventilators. In most cases, early intervention with CPAP will allow reasonable arterial oxygen tensions with inspired oxygen concentrations of less than 60%. It must be remembered that the normal newborn has an arterial PO2 of between 40 and 70 millimeters Hg. The establishment of continuous positive airway pressure should 1. Increase the functional residual capacity. 2. Decrease the work of breathing. 3. Increase arterial oxygenation. Chapter 24. Careful attention must be paid to the infant's thermal environment since the increased oxygen consumption related to sub or above normal body temperatures will further compromise the amount of oxygen available to vital organ systems. Retrolental fibroplasia. Retrolental fibroplasia occurs primarily in premature infants in whom the retinal arteries have not developed fully. Arterial PO2s above 150 millimeters Hg for as little as 4 hours may cause malformation of these arteries and lead to blindness. This malformation is probably due to arteriolar vasoconstriction that occurs with arterial PO2s above 100 millimeters Hg, even after the excessive oxygen therapy has been discontinued. An infant who has been exposed to high PO2s is not out of danger. As the infant matures, new vessels may grow in a disorderly manner, causing scarring and retinal detachment. The general rule is to keep the inspired oxygen concentrations below 40% in the newborn. With the normal degree of alveolar collapse and poor expansion of newborn lung, an inspired oxygen concentration of 40% will seldom result in arterial PO2s above 100 millimeters Hg. It is desirable to monitor the newborn's blood gases and to keep the arterial PO2s below 80 millimeters Hg if long-term oxygen therapy is required. Remember, it is not the concentration of oxygen exposed to the eyeball that causes retrolental fibroplasia, but rather the arterial PO2. Infants who are hypoxemic must be provided with oxygen therapy, 100% oxygen administered to a severely cyanotic baby will not result in aplasia because arterial PO are not above 100 millimeters Hg. Peace, Marquise. Here we go. Marquise, build it up, build it up, build it up. Here we go. Summary. Page 516. The basic principles of adult respiratory care may apply to the pediatric patient, with the exception of the techniques and specific differences discussed in the chapter. One must remember that it takes a great deal of training, skill, and knowledge to apply respiratory therapy successfully to the neonate and infant. Those respiratory care practitioners with special interests and training in pediatrics should be the ones involved in the specialized care of these small children. We did it. We completed another book on YouTube. I'm so honored, so grateful and thankful. We did it. We did it. Look at all of the feathers coming in. Place at the end. I will put the vocabulary in the description. We did it. Together. We did it. We completed a 500 plus medical book. Live from the light here in LA. All of the super hard vocabulary. We did it. We completed. And you were here to see it. Highest hard love and honor. We did it. So grateful and thankful. So, what do we have to do now? We have to hit the chimes, right? Let me give this reading of a thanks. Woo! Yes, Michelle. Thank you so much. That's beautiful. We did it together. Super high vocabulary. We completed it. 500 plus pages. So, honors and acknowledgments. First of all love and honor to all the ancestors guiding me. So grateful and thankful, and I'm listening. I'm doing it. Thank you to the authors of this masterful book and manual. Highest heart love to Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Honor and love to my parents, Kevin and Wilma Calloway Riley. I love you so much. You've always encouraged me. You always love me. I love you. To all my family and friends, my brother and sister, I love you. Says, love to my parents who always are rooting for me, especially my mom, the teacher, master teacher she is, that sat with me when I couldn't even walk and taught me to read. Special thanks and honor to Bethany Dixon. Bethany, you said I should do it. And I could do it regarding reading this medical information and book. And you encouraged me to do it. And so when you said, Uriel, read that medical book. If you wouldn't have said that to me, I probably would have skipped over reading it. So reverence and honor to my great friend, my moderator, great mate, Bethany Dixon. Or else we wouldn't be here right now. That's for sure, reading that book. Highest heart love to all that were cheering us on and me on to read and complete this book. I hear you clear. I hear you clear and loud. And it was fueling me to continue. So thank you, all of you out there, all of you. Yes. We did it again. We did it again. Sing it with me. I love you. I love you. You know it. Clinical application of respiratory care. So now I'm going to hit the chime. We did it. Right at 1 hour. Look at this. Time to hit the chime. We did it. We did it. So grateful and thankful. Thank you so much for being here. I will see you soon when we reconvene. Highest heart love. We did it. Peace, peace. I love you. Glass of love water. Dedicated. We are the truth. Peace, peace.